right, so breast cancer triple negative. So today we'll be first defining breast cancer, talking a little bit about the epidemiology of it, and going over a little bit of anatomy. Don't worry, we're not going to make this a medical school lecture. And we'll talk about different types of breast cancer, including triple negative breast cancer, some of the risk factors associated with it, as well as the workup and diagnosis of it and the treatment. So let's start. What is breast cancer? It essentially is a disease in which there is uncontrolled growth of abnormal breast cells. It can be cancerous or malignant, which means it has the ability to spread. It often begins in the lobules and the ducts of the breast, but it can spread to other places. In the United States, according to the most recent data that has been collected by the CDC, the Centers of Disease Control, 250,000 plus new cases of female breast cancers were reported among women. The data that I'm reporting is from 2017, which is the most recent aggregate of information that we have. The information is not reported every year. They aggregate it every few years and do analyses based on that. So 42,000 women died of breast cancer of the 250,000 diagnosed of the new cases. For every 100,000 women, 125 new female breast cancer cases were reported, and 20 women died. Cancer in the breast is the second leading cause of death in the United States. It's only surpassed by heart disease. So I'm going to have a few graphs here. You don't have to get too overly focused on this. I'm going to give you the synopsis of it, okay? I just think it's very important to see this information because it's a real problem, a real disease that we really need to have a good grasp of. So in 2017, the new cases or the incidence of breast cancer were 125.1 per 100,000 women, okay? It was followed by lung and colon cancer and uterine cancer and some other cancers as well. But if you look at this blue line here, you can see that breast cancer far exceeded the others. Sorry about that. In terms of the deaths, the mortality, you can see that breast cancer was only second to lung cancer in terms of deaths in 2017. 30.6 deaths per 100,000 patients. So again, you see this orange line here. It was only surpassed by lung and bronchial cancer. So now, when we talk about where in the United States we see the highest rates of breast cancer, some of these states might actually surprise you. The highest rates start at the District of Columbia, so DC, Hawaii, New Jersey, Minnesota, Montana, Rhode Island, Iowa, Connecticut, which is where I live, New Hampshire, and Idaho. So these are some of the highest rates per capita per 100,000 women of breast cancer in the United States. That includes all races, all ethnicities, and all ages. So, all right, I showed you guys a bunch of graphs, showed you some pretty colors, and showed you a lot of data. So, what does this actually mean, right? How do you actually take this data and translate it into what it means for you? So, your lifetime risk is 1 in 8. So that means 1 in 8 women is going to develop breast cancer in their lifetime. Okay. That's a 12.5. If you round it up, that's a 13% risk. Screening. When we screen, now we have so many different screening modalities, and we also have a lot of education that's surrounding screening that we provide to the public, we provide to our patients. So screening has been found to be associated with approximately a 25% decrease in mortality, so the deaths associated with breast cancer, which is significant. And though we do screen, particularly with mammograms, the screening is not perfect. So there can be breast cancers that are missed by mammograms. About 10% of patients who will develop a breast cancer will not be it will not be detected on a mammogram. So mammograms miss about 10% of cancers. That's really important to understand. Despite our best screening modalities, there are still some areas and things that we can develop and get better at. So I wanted to take a pause here to make sure that everyone's doing okay. Are there any questions so far?
So right now we have one question in the chat and it was a definition question. Can you define a lobule? I think from the anatomy
From
of
the
the
lobule?
yes.
Yes, actually, if you don't mind, I'm gonna pause. That's actually on the next slide. It's the next section, so we're gonna actually discuss that in a minute, if that's okay.
That is the only question that we have thus far.
Okay. All right, perfect. Well, we'll continue then. So, basic anatomy. There are three main parts to the breast. We have lobules, ducts, and connective tissue. So, the question in the chat was, what's a lobule? Well, a lobule, as you can see, is a lobe of a portion of the breast, which are in the lobes, right? The lobes have lobules, and these lobules produce milk. So, they're a portion of the breast that produce milk. Then you have ducts. Ducts carry the milk from the lobules. Can you all see my mouse? Is it kind of tracing? Can you see the mouse? Okay. So we talked about the lobes here. So these are lobules. And then we have these ducts over here. So these ducts actually carry the milk from the lobules. Okay. And they carry it towards the nipple, right? So when a woman is, lactating and breastfeeding and, they're able to produce milk and feed a child. Um, the connective tissue, which is all this kind of yellow stuff that you see it here, is fat, right? It's essentially fat that keeps everything together. It holds the structure of the breast, but doesn't have much production uh, capacity. It doesn't produce the milk or transport the milk. Okay. And then behind that fat, you can see a lot of muscle tissue and then your ribs. Okay. So that's the only basic anatomy we're going to do today. But it's important to understand the ducts and the lobules when it refers to the types of cancers that we have, which we'll talk about a little bit later. All right. So now it's a little bit later. Now, in terms of the types of breast cancers, there are several different types of breast cancers, but the two most common breast cancers, in which a lot of the other breast cancers are subtypes of, include invasive ductal carcinoma, which is about 50 to 80% of breast cancers. It's the most common. In these patients, cancer cells grow outside the ducts into other parts of the breast. So the actual cancer starts in the ducts, goes outside of them to the other breast tissue. Invasive lobular carcinoma, which is the second most common, and that's about 5 to 15% of patients. The cancer cells spread from the lobules to the breast tissues that are nearby. So remember, the three main parts of the breast were the lobules, the ducts, and the connective tissue. So majority of the cancers are from the ducts or the lobules. Now, there are two types of lesions that are important to understand, and they are not considered cancers. So, up here are our cancers, and here are some other lesions that you may have heard someone been diagnosed with, you may yourself have been diagnosed with. So, they're important to understand as well. Ductal carcinoma in situ is a precancerous lesion. Okay. So they are cells that are becoming cancer and they're lining the ducts, but they have not spread outside of the ducts. So it's in situ. Okay. It's in the ducts. It is not spread. Lobular carcinoma in situ is not a cancer. It is a tumor marker. It basically is a change in the cells, so atypia or atypical cells. So the cells are changing, they have not spread, and they have a lesser chance of becoming cancerous than the ductal carcinoma in situ. Okay, so it's important to understand those two as well. So receptors. Here's another thing that you may have heard about in, in literature, commercials, and things like that. When we talk about the different receptors of breast cancer, we're referring to estrogen or ER, progesterone or PR, or human epidermal growth factor, which is a type of protein, which is also referred to as HER2. So these are receptors that live on cancer cells. Okay. So if you were to think of the cancer cells as a house, so that's why I have this little picture here. If you thought about the cancer cells as an actual house, to get inside to actually destroy the cancer, we have to bypass some locks on the door, right? So the locks on the door are estrogen, progesterone, and HER2. Now, if your cancer tests positive for these three locks, which are known as the receptors, then we as doctors have some keys that we can actually use to get inside the house and or the cell to destroy the cancer. We call it targeted hormonal therapy. However, if you have triple negative breast cancer, so what that means is that you do not have these receptors on the cancer or the tumor cells, then we're not able to fight them with our classic tools. Okay. So triple negative breast cancer accounts for about 10 to 15% of all breast cancers. If you have triple negative, those locks are not there, as you see the big X's on the screen. So the keys that the doctors use don't really work. Our typical keys don't work. But fortunately, we still have chemotherapy that is still an effective option that we'll talk a little bit about shortly. So it's important to understand the difference between receptors, ER, PR, HER2, in any particular breast cancer can be an ER positive, it can be a PR positive, it could be an ER and PR positive, it could be an ER, PR, and HER2 positive. However, it can also be a triple negative, which is negative for all three of those keys. Okay. So, why are we talking so much about this? What's the big deal about triple negative breast cancer? All right. So, the big deal is that triple negative grows very fast and it spreads a lot faster than typical cancers. Not only does it grow where it's coming from, it spreads to other locations faster than usual. And because I just explained what the keys in the house, we have limited treatment options. Our main treatment option is chemotherapy. And overall, it fares a worse prognosis because it's difficult to treat and we don't have approved targeted treatment. So remember, the targeted treatments are targeted at those hormonal receptors. We don't have targets, right, without having these receptors when we have triple negative breast cancer. The outlook is usually not as good, unfortunately. So, who is getting triple negative breast cancer, right? So, we said it's not that great. It spreads fast. It's more aggressive. We don't have a lot of treatment options. So, who's getting it? Unfortunately, young women are. We are. Young women, usually under age 40, usually women who are of African American descent, as well as women that are Latinx. It's far greater in the African American population. The genetics of it, and we'll talk a little bit about this coming up with Dr. Collins as well. But a lot of patients who are getting triple negative breast cancer are also patients who have genetic mutations, like the BRCA1 mutation. About 20 to up to 20% of patients have been found to have this. The BRCA is a breast cancer susceptibility gene that's really important for us to know about if someone has a family history of it or personal history of it, because genetic testing needs to be done for other family members because it can really run in the family. And other risk factors that are associated with this include being premenopausal, obesity, uh, and having your first pregnancy at a young age. These are all risk factors that are associated with triple negative. Okay. Like I said, I'm going to reiterate it one more time about that BRCA1 mutation. It is a genetic mutation. It is a gene that can be tested for with genetic testing. So it's important if you're, especially under age 60 years old, developing triple negative breast cancer, you do need to be evaluated as well as other people in your family. All right. So I hope you guys are learning and you're doing great. So let's do another poll. Okay. It's really important for us to know some of these common misconceptions. So what we'll do is we'll launch the poll and we'll just kind of ask some questions. And these are pretty much going to be true false questions. Okay. So we want to see where everyone's at, what people think are truths, what they think are false, and then we'll discuss them. Okay. So the first question is if no family members have breast cancer, my risk is low. True or false? Is the poll launched? There we go. Perfect.
How long do you want to give them for the poll?
I was thinking let's give maybe another 10 seconds or so, see what we get.
Okay. So we'll go ahead and end it. We have 17 of the 20 who have responded. So you should be able to see the poll. We have 13 participants who believe it is false, and then 4 participants who believe that it may be true.
Excellent. So it looks like the majority of you all, 76%, believe that this is false, and that is correct. Dr. Collins, would you like to talk to us a little bit about this?
Absolutely. And I just wanted to say before I start, thank you for having me. It's my honor to be here. Thank you for your attention and your interest. So, going into this, one of the misconceptions that people can have is that breast cancer can be thought of as being only inherited through the families, which what we know about that is not true. Only 20% of all breast cancers are considered inherited through the family. So that means that 80%, the majority of breast cancers, are what we call sporadic, or that it means they just happen kind of out of the blue to you. So it doesn't, your risk is not low. And that's why we recommend all women starting at a certain age get screening mammograms.
All right. So we'll go on to the second question. The second poll: ethnicity does not play a part in breast cancer. And go.
Okay, so same number, 16 out of 20 people. This one, we have 13 participants who believe that it is false and 3 participants who believe that it is true.
Okay, excellent. So it looks like the overwhelming majority, 81% of you all think that this is false, and that is correct. Dr. Collins?
Yes, thank you. So, as our topic will continue to focus on the remainder of our time, you'll see that ethnicity does play a role in differences in breast cancer, and it's not necessarily all for the bad or for the good. As we know, Black women typically have an overall lower incidence or chance of getting breast cancer. But the negative side effect of that is that we do know that Black women and Hispanic women have an overall lower survival, so more deaths in this ethnic group. So ethnic backgrounds do play a part in breast cancer care, treatment, and survival.
Thank you, Dr. Collins. Now, when you get breast cancer, you need both breasts removed to reduce your risk. Here's another true or false poll for you all.
Okay, so this one we have, well, back to our magical number of 16 out of the 20 participants. So we have 14 participants who believe that it is false, and 3 participants, taking us actually up to 17, who believe that it is true.
All right. And the answer is false. 82% of you all believed it was false. Dr. Collins?
Thank you. So, yes. So the key to this statement to that I wanted to make note of is that you do not need to have your breasts removed if you have the diagnosis of breast cancer. It is what we call a risk reducing strategy, but it does not improve your overall lifetime survival. So, this is a discussion that you would have with your surgeon or your cancer doctors. What is the right strategy for me? And for some people, um, getting closely monitored with mammograms is just as equivalent as to having the full breast removed. So you do not need to have it done. It is an option to you, but you do not need it.
Thank you, Dr. Collins.
Yes.
All right. So I'm going to go ahead and hand it over to my colleague, Dr. Collins, to talk to us a little bit about some disparities, a complex topic.
Very complex. Thank you. So I wanted to make sure that we touched on this because we're starting to scratch the surface of our talk on triple negative breast cancer and how ethnic backgrounds can relate to that. And so one of the components of this is the disparity of why survival is lower for Black women and Hispanic women. So many studies have been done, including studies that are survey respondents of people in that ethnic background. And what they found is that insurance coverage is a big component to the disparity, but only accounts for a small portion, 35% of it. And what does that mean to us? So insurance is access to the resources, having the hospitals around, having the physicians who deal with that kind of cancer. If you don't have insurance at all, obviously that's a lack of, of gaining access to those to begin with. The studies have shown that Black women are 3 times more likely to be uninsured or on Medicare coverage than white women. This is what contributes to some of the disparities in the treatment and care plans of those women. Additionally, it's noted that the access can be to healthcare facilities such as local health departments, which are maybe not the most accredited facilities or the physicians who deal with cancer care. Because of that, that can lead to what we call kind of a provider neglect. If it's not the person, the provider, the physician who deals with those, they don't necessarily order routine mammograms, they don't follow up on those, they don't have a close relationship with the patient. That can lead to delays in the treatment or the diagnosis. So that's a component of a provider neglect. The other thing that we do know is that historically there are disparities in the medical profession. Historically, it's been a white male profession. We do know in the last 20 years or so that more women in general are going into medicine. The latest thing that I read was 60% of physicians under the age of 35 are now women. So these trends in historical medicine are changing of the discrimination and disparity from male physicians to female patients. So, and this is across all ethnicities. When women would go to the physician and state certain symptoms, they were either dismissed or not taken as seriously. This is where we get the diagnosis of hysteria because women were considered emotional, hysterical, dramatic, and kind of pushed aside and not taken seriously. Because of that, that can lead to a distrust in the medical system. Obviously, there are also discriminations within the medical system. There are less minority groups as physicians, and that has inherited a distrust in the medical system between women of all ethnic backgrounds. The other components that I just want to touch on that are in here are related to the media. So some of the survey respondents had mentioned that when they see discussions of breast cancer in the news or Instagram or whatever, they see white women. So this historically was considered a white woman's disease. Because they don't see representation of themselves in the media, they felt that it was not something that would affect them. Otherwise, they would see themselves in that situation. Additionally, there's different things such as socioeconomic factors related to low income status. That can be if you're worried about how you're going to take care of your family, your children, most likely your preventative cancer screening is not at the top of your list. Typically, women take the role of care provider to their family. If you're more worried about your child, their education, how they're getting to and from school, how you're working, your breast cancer future thoughts are probably not at the top of your list. So all of these things combined into a disparity that we know affects survival for minority group women. Could you advance the slide, please? Thank you. So to relate this back to our triple negative breast cancer, overall, in all ethnic groups, triple negative breast cancer, as Dr. Segenrow mentioned, is a very aggressive cancer. It's larger in size, it's more likely to have spread. So overall, all women, all comers, the survival is lower. because it's diagnosed at a more advanced stage, that's what causes the higher mortality rates in general. So what we know for why that's important is that 1/3 of the women less than 50 years old who get triple negative breast cancer are Black women. So can we advance the slide? Sorry, that was the last point. Yeah, thank you. So I wanted to discuss the disparities, and then I wanted to discuss some of the risk factors. And these we'll talk about the ones that are something that you can do something about. So our risk factors, family histories, we talked, is a component. There's nothing that you can do about the fact if your mom or your grandmother had breast cancer. As you age, your risk of breast cancer increases with age. Again, there's nothing you can do the fact that you're going to age. Your ethnic background, there's absolutely nothing that you can do to control that. So now we get to the ones that we can control. So the things that we know affect our breast cancer risk as women is our BMI, which is a measurement of body fat index or obesity, your alcohol consumption, smoking, and whether or not if after menopause, which is when you stop having periods, if you took supplemental hormones. The hormones, as Dr. Suganro mentioned, are the receptors that affect how the cancer grows. The more hormones you have in your body throughout your life can affect your risk to develop those cancers. Excuse me. The next topic is pretty much things that you can't control, but menarche is the time of your first period. Nulliparity means not having any children. The first, your age at your first birth of your child, menopause, or when you have your last period, and the one that we can affect is whether or not you take oral contraceptive pills. Other risk factors that, again, I have no control over are if you've had to have biopsies of the breast because there were abnormalities found, if you have dense breasts, if you were born with dense breasts, and if you've had prior radiation, whether you had chest radiation for a childhood medical problem. Let me advance the slide, please. Great. So just touching on some of the things that we can do to reduce our risk of breast cancer. So the big one that we always talk about is reducing obesity. And so obesity in postmenopausal women, so women who have finished having their periods, that's where this is the most significant. Being overweight or obese during your menopause years doesn't seem to affect it the same way. But for every 11 pounds that were considered overweight after we finish having periods is an increase of 11% chance of increasing our risk of breast cancer. So managing your weight, eating a healthy balanced diet, fruits, vegetables, etc. We'll touch on this a little bit more about some misconceptions with diet itself. The other one I wanted to touch on was reducing alcohol consumption. So we have definitions of what alcohol consumption is. Typically it's 10 grams or 12 ounces, which is, about that much is considered one drink per day. That one drink per day increases your risk of breast cancer 7 to 8%. So we typically recommend for people to have 1 to 2 drinks per week to keep their risk of breast cancer low. If you're drinking 2 to 3 drinks per day, each day per week, that's an increased risk of breast cancer of 20%. The reason that we know that that alcohol and obesity affect our risk is because of how they affect the hormones in our body. So with the hormones affecting our cancer cells, the most that we can do to reduce those hormone fluctuations and increase hormone exposure decreases our risk of the breast cancer. And then breastfeeding I wanted to touch on because it is an option to you that can help reduce your risk because it's considered protective. While you're breastfeeding, your estrogen levels in your body are low, and so that reduces the risk of your breast cancer while you're breastfeeding. Can we advance? Thank you. Perfect. Any questions so far?
So we do have 2 questions, and you'll probably get to these later, but I'll ask them anyway. The first is it recommended to have a mammogram done twice a year? I don't know if you want to answer that now or wait.
I can answer it quickly and we can get more into it. There are certain situations, such as if you have something found on your mammogram we don't think it's suspicious for cancer, but we're not quite sure what it is, then we might recommend having a mammogram every 6 months to keep an eye on a spot. But if you have nothing wrong with your breast, typically it's once a year that we recommend having a mammogram.
And the second one is, does menopause play a role in breast cancer development?
Um, yes and no. So hormone fluctuations can play a role. We do know that as you age, that the more likely you are to develop breast cancer. But being postmenopausal itself does not increase your risk. It's these life factors that can go along with being menopausal or postmenopausal that can increase your risk.
And those are the only two questions. We did have a comment roll in. Basically, they just reported a huge eye opener about the increase in weight and drinks in correlation with the development of breast cancer. So, some of those modifiable risk factors.
Amazing. I'm glad to see that that was educational.
Yes, those risk factors are extremely important, and we don't talk about them a lot. I think sometimes people don't realize that our lifestyle can definitely contribute to a lot of the disease processes that we have. So it's important to identify those and try and modify them when we can. So thank you for that comment.
Perfect. So we'll get a little bit more. We wanted to touch on the different types of imaging that we do to diagnose cancer, just so everybody's familiar with the words and what they mean and when you might get them done. So the takeaway from this slide is the mammogram is the always. You should always have your mammograms. If your physician orders you an ultrasound or an MRI, that's fine, but the mammogram is the go-to. So what a mammogram is it's kind of an X-ray of the breast. It will show you a picture here in a minute for those who aren't familiar or haven't undergone them yet. But it basically compresses the breast between two plates. It puts a significant amount of pressure because it needs to flatten the breast so that the x-rays can see through it to try and find any tissue abnormality. But it's very specific and it's very sensitive. And the majority of things are found on mammogram, which is why it's the gold standard. And we'll talk about screening recommendations, but why we recommend you having that once or twice per year. And then the ultrasound. So ultrasound is like when you're pregnant, same concept. We use an ultrasound gel. There's a probe and we wave it over the breast tissue. We can look behind the nipple and we can also look into the armpit. It is a different way of looking at the tissue, but it can give us a little bit more information about what things look like compared to the x-rays. So typically, if you find an abnormality on a mammogram, you might find that your physician orders more mammogram pictures to get a better view, and we'll add an ultrasound to that. It helps us classify what we're looking at. The MRI, this is not usually ordered for all patients. This is usually ordered for patients who are considered high risk or have a significant family history of breast cancer, or their breast tissue we call it very active, meaning there's a lot of spots that can look concerning on the mammogram that we need just a little bit extra detail. MRIs can be done throughout the whole body, but what's significant about this is it's specific to the breast tissue. So not everybody needs one. Sometimes you might get one. Then the biopsy is if we do find an abnormality in the breast tissue, they might recommend a biopsy. And what that does is that is a needle that goes through the breast tissue and grabs a little tiny bite of the tissue so that we can look at it under microscopes to see, do the cells look like they contain cancer? And this is how we get our diagnosis to start talking about treatment plans. Next slide, please. Thank you. So this slide is the tiniest bit busy, but what the take home we want you to have from this is that in the red, this is talking about screening mammograms. So in the red is the one I'll focus on, but down the top to bottom side are different organizations of physicians that treat cancers and their recommendations of how mammograms should go, when you should get them, how often you should get them. And you'll see across the bottom is women's age. So pretty much unanimously, everybody agrees at age 40, you should start having the discussion. SDM in the pink means shared decision making. And what that means is you talk to your physician, I'm 40 years old, should we start my breast cancer screening with a mammogram? So I'm going to focus on American Cancer Society because that's what in this country most of the breast physicians look at. So at age 40 through 45 is when we have shared decision making. Should we start? We can start. At age 45 to 55, they recommend annual, having a mammogram once a year annually. And as long as nothing is found and your breasts look normal, you'll continue once annually for those 10 years. Once you get to age 55, then we start talking about, can you go to every other year? So I'm just going to add a little bit of my personal opinion to this. I consider myself a very conservative physician to my patients. I feel that I would rather get more imaging and not miss a cancer than have you go every other year and miss something. So I advocate for my patients at age 40, we start your screening and we go every year. I think it makes it less confusing. Some people don't like it because nobody really likes to go get their breast compressed once a year. It's a hassle, taking time off work, doesn't feel great. But I think the peace of mind of having something that we can compare to every year makes me and hopefully my patient feel more comfortable with their care. That's me personally. Your own physician might have different opinions, but classically, that's what we recommend. Starting at age 40, have the discussion with your doctor. By age 45, you should be having an annual mammogram. And then just to kind of give an idea for those who haven't experienced one, this is kind of what it looks like. So they place the breast between the two plates here. They compress the breast. There is a significant amount of pressure to flatten out the breast. Nobody really likes it. Next slide. And so just to touch on, to kind of pull it full circle, so we wrap up this discussion of triple negative breast cancer. I'll start out by saying how we treat breast cancer. So not all breast cancers are the same. As Dr. Suganrode talked about, the different receptors give us what we call different subtypes. So this is the subtype of triple negative. How we treat this is multi-modality, different ways, and they all work together. So the three main components of a breast cancer treatment is surgery, chemotherapy, and at times radiation. For triple negative, most of the time as we talked, it's aggressive, it's larger, and it's spread. So we typically go to a chemotherapy-based treatment first. Patients will get access to their veins where we put medication through IV, and those medications go throughout the whole body. They target the cancer cells and they try and destroy the cancer cell. Our hope also is that it shrinks the cancer to make the surgery to remove that cancer easier. If the cancer has diffusely spread, which means it's gone from the breast typically to the what we call lymph nodes in the armpit, and this is kind of the highway, the gateway to it spreading to brain, lungs, and liver. That's the most common place breast cancer will spread. Most of the treatment is just chemotherapy based because survival is so low at that point. And then in the certain cases, radiation would be recommended. And just to give a brief discussion of what radiation is, radiation's kind of like a laser light therapy that you can't see and you don't feel. And it gives kind of a sunburn to the skin right over the area of the breast. And the thought is those laser lights that we can't see or feel will destroy any tiny little cells that are left behind that could contain cancer after we take out the cancer with the surgery. So, and then we also treat lymph nodes if they have any cancer cells in them with radiation. Perfect. And then the final topic just to discuss, because we did talk about whether or not you need a mastectomy or not. The two options that we talk to patients about is what's called a lumpectomy. And what that is basically just removing the chunk of tissue from the breast that contains the cancer and a rim of normal breast tissue to make sure that we got it all. If you do that and you just remove that chunk of cancer cells, you must have the radiation to your breast, because that's, as I just said, we're targeting any little tiny cells that could be left behind, to prevent you from getting a recurrent breast cancer. So if we remove the chunk, you have to get radiation. The alternative to that is having the full breast removed. Anytime we're doing either of those surgeries, we have to see, has the cancer spread? We need to know definitively. So that's when we'll do the surgery and we test lymph nodes. That means we take one or two of the lymph nodes, we look at them under the microscope, and we say, yes, cancer is here, or no, it's not. And sometimes we have to remove all of the lymph nodes from underneath the armpit to get rid of cancer cells that have spread to that area. So that's kind of the superficial 30,000 view of treatment of triple negative breast cancer and kind of cancer itself, breast cancer itself.
Absolutely. So thank you so much. And we just wanted to kind of recap on what we learned today. So, really, we want to reiterate to you all, if you feel something abnormal, talk to your doctor, talk to your provider, let them know that you're concerned, because if you're concerned, we're concerned. So it's important to make sure that you don't keep that under wraps or keep it to yourself. And next, we want to focus on the things you can control. Dr. Collins really hit this, point on the head, that weight management and BMI control is very important. And some of the modifiable uh, lifestyle risk factors, such as alcohol consumption and tobacco, are also important too. So really, let's keep that in mind. And also get your annual mammogram. We talked about some of the different ages with mammogram screening. And like Dr. Collins said, classically and traditionally, we still suggest age 40. And without a particular abnormality and just routine screening, it's usually yearly. So the key for breast cancer is early detection, so we can provide early treatment options and modalities for you. So, Dr. Collins, if you want to talk to us about some of these organizations that focus on the disparities.
Sure. As I was kind of preparing myself for the discussion, these are what I came across that are specifically focused to Black women, and so they give information that's specific to the risk of, Black women's risk of breast cancer. So if you're interested, they offer a lot of information, as well as the traditional sites, but they're less focused on Black women's health.
Absolutely. So, with that said, thank you all so much. And, it's been an honor to be able to discuss breast cancer with you all. And again, thank you so much to Nicole for inviting us to do this. It's been a pleasure. Thank you so much to Dr. Collins. And we just really want to open this up and have a discussion and let you all answer. Oh, well, we'll hopefully answer, and you all ask some questions that we can answer for you all. So with that said, Nicole, are there some other questions? And if we want to go ahead and open it up to everyone.
So we do have two questions in the chat. I don't know if she wants to ask them herself or if she wants me to read them out of the chat. Um, so I don't see her hand raised. I'll at least start with the first one. So the first one was, what information do you have on the connection between aluminum and antiperspirants and increased breast cancer risk?
Sure, great question. Dr. Sigmund, would you like me to answer this one?
Yeah, please go ahead.
I don't want to steal the spotlight too much.
No, please go ahead, girl.
So it's an excellent question. Great question. Thank you for bringing it up. Again, this is a misconception. So there have been studies in the past, and this study in particular was done by a group of OB and gynecologists that correlated the aluminum in antiperspirants for potentially having an increased risk of breast cancer. The follow-up studies that were done to try and recreate this information showed no correlation. We do not recommend to any patient any different types of antiperspirants or avoiding them or natural. It's your preference, whatever you'd like. Your deodorants and antiperspirants will not cause you to get a breast cancer. Kind of as a sideline of that too, because I forgot to kind of touch on it. As far as the diet, I have a lot of patients ask me once they're diagnosed with cancer, was it something that I ate that, caused me to get breast cancer? And the answer is from all of the information that we know, and we've been studying how diet affects cancers for the last 50 to 80 years, is that no, there's no correlation of any specific type of food, wheat, grains, dairies, anything specific that would cause you to get a breast cancer. These are mutations that happen at a cellular level of the DNA in our cells that, while we always recommend you to be a healthy person and eat healthy foods, keep your body healthy, keep yourself active, get plenty of macronutrients of what we consider vitamins, minerals, all of the things that you would eat to be a healthy person. But none of them will cause you to have breast cancer, and none of them will help treat any kind of breast cancer. So just a side note on that too.
So the next one you probably just kind of touched on, but I'll go ahead and ask it anyway. It's since estrogen in fat cells is a risk factor, would you recommend not consuming foods that contain phytoestrogens such as soy milk and soy-based processed foods?
Good question. So I'll be 100% transparent. I don't have a lot of knowledge on soy-based products and their effect of estrogens, but what that tells me is that it doesn't matter, because if it was such a big component, it'd be something that I would know about to be telling patients to avoid it. So again, nothing that we typically eat affects it. I can see where the correlation could be taken from a soy to an estrogen, but none of those studies have shown at this time to have any direct correlation. So you should be fine with your soy products and your soy milks, etc.
100%. Just to echo that, Dr. Collins. There have been a lot of studies that have been looking into this, particularly in a lot of countries in Asia. They've been looking into this phenomenon, and those studies have not been some have not been conclusive, and a lot have not proven that it has had an effect. That's the actual current stance of the American Cancer Society in the United States. Next question.
I see a few questions in our little chat thing
Yeah,
too.
I
So
see.
we'll do, yeah, there's a couple there, but we do have someone with her hand raised, so I will unmute her.
Okay.
Um, let's see, Keisha.
Yes. Hi. I have a comment and a question. The first comment, for those who may not regularly go and do their annual mammogram, one thing I am appreciative of it, at least the place that I go to, they get you in and out quick. It's almost like we already know that you're stressed out enough to come get this, so let's get this out of the way. Bam, bam, bam. Today I had mine done 15 minutes top.
Wow.
Was in, checked in, registered. I checked in online. Made my appointment online. Within 3 days. Today I went in at 3:30 and I was out at 3:50. And it's just and I could go to this place continuously. I don't know if I can say the name of the place, but it's at Medical City, Dallas. And just as they deal, they'll get you in, get you out, and just sort of walk you through and talk you through so you're comfortable. Um, my question is that I take estradiol. I know that you said that there is no correlation between soy and other deals, but I would like to sort of taper off of it. But my question is there an impact of whether breast cancer, any type of cancers will take in that? Because I've been taking it for a while because I can't deal with the hot flash.
Fair enough. I appreciate that. My mother is also in a similar situation. And so in the short term of taking those, we consider those newer estrogens. So a lot of the hormone replacement therapies that were given to women in the 70s, 80s, and 90s are of a different variety than what they give today, a different kind of strength. So in the short term, no, it's fine to take those, but obviously the sooner that you can come off of them, any exogenous hormone replacements or anything like that, can affect overall risk, but it's so small with such a short amount of time that we don't get too worked up about those.
Absolutely. It's usually the long term hormone replacement therapy use that really is problematic. That'll increase your blood levels of the estradiol. So 100%, Dr. Collins.
Thank you.
And then we do have two in the chat. First one is, should we be worried about calcium deposits?
I'll go ahead and take this one, Dr. Collins, if you're okay with that. So, one of the things about calcifications that's important to understand is generally calcifications can be benign, right? So when we have just a few calcifications here and there in our breast tissue, that can be benign. But when we start to have clusters of calcifications that are irregularly clustered together, multiple clusters, clusters that change over time. So, for example, if we see some calcifications on a mammogram, this year, so we're in 2020, so in this year, and then when we redo your mammogram next year, if those calcifications look a lot larger, look different, look more irregular shape, we get concerned. So calcifications can start off as a benign and not very alarming concern. However, there are certain types of calcifications, certain shapes, and certain arrangements of them that can also be very concerning. So the mammogram actually is very great at finding calcifications. Calcifications show up very well on mammograms, and a lot of times those abnormal calcifications are what clue us into an abnormality in the breast.
There's one more. Is it true that blackberries or raspberries fight off cancer cells?
So the thought, postulation and theory behind this is that those are traditionally foods that are high in antioxidants, and antioxidants, in theory, help fight with your cells against cancer cells and mutations in your DNA. But it's kind of just the theory. Again, there's been no hard research or evidence that correlates if you eat this amount of blueberries or raspberries or spinach, because that's antioxidant, that it will prevent you from getting a type of cancer, any type of cancer. So they're healthy, they're fruits. So it would be a good strategy to maintain them in your diet, but to exclusively eat them to try and prevent a breast cancer is probably unlikely.
Agreed. I think it's very important, speaking on a similar topic, is, a lot of people get information out there, right? So we get inundated with commercials or health adjunct people who come out and give their opinions about certain things. And I think we have to remember opinion versus science. And so a lot of things, yes, our opinion, right? So, theoretically, could those things help? Yes. But have they been proven to? No. So just I recommend to anyone, and not just breast cancer, anything, when you're hearing someone kind of tote that, a particular supplement, as a particular vitamin or fruit or something like that will cure something, look into the science of it, and don't kind of get swept up with that. It's important to make sure that we look into science and fact. When it comes to disease processes, I think it's important to believe the experts and believe the scientists and the doctors and the providers who are trying to definitely help you fight it. So
My closing statement would be, please get your mammograms starting at age 40 and annually there forward. And thank you very much for letting me be a part of this tonight.
thank you. My closing statement would be, please talk to your physician, your provider, and keep us in the loop. Don't keep things to yourself, and don't let it be too late. Unfortunately, we are getting patients that are diagnosed at later and later stages in a disease that we are learning a lot more about and developing tools on a regular basis to help fight. So at this point, it's really important to get tested, get your mammograms, and talk to your provider if you think something's abnormal. Because if you're worried about it, we will be too. So, reach out to us if you have any other questions or concerns. And again, thank you so much, Nicole and the Zeta sorority, for allowing us and having us here today. It's been an absolute pleasure. And thank you all.
Hold on, we have one more. Can we do one more question really quick?
Absolutely.
Age 40, so we've been doing a lot of emphasis on the age of 40. This particular question is, are 35-year baselines still happening?
No. Across the board, for screening mammograms would be at age 40. Um, if you have a high risk, uh, as in a family member, you should have your baseline mammogram at 10 years earlier than their diagnosis. So, obviously, if you're feeling masses or breast issues, that would lead you to have what we call a diagnostic mammogram. So you're not screening the just in case to look for cancer. You feel something doesn't feel right, and we're trying to figure out what's this diagnosis of what doesn't feel right. So there's a little bit of difference between screening mammogram and diagnostic mammogram. And then at age 35, there's no recommendation for baseline screening of normal risk women. It all starts at age 40. If you have breast history, and if there was any kind of new concern, or if they thought in your family, if you have any family history, all of those things kind of go in that decision making. For you at this stage, if that last mammogram at age 35 was normal, if you're now 37, we typically would say if that one was normal, you don't need to have any more mammograms until you're age 40. So unless you continue to have issues on those mammograms, you should be fine until age 40.
So that is all of the questions that we have in the chat, as well as hands raised. So I do appreciate the two of you ladies taking time out of your Wednesday afternoon to come together with us and teach us some things, educate us a little bit in regards to breast cancer, as well as things that we can do amongst ourselves to kind of help, if we're going to be diagnosed, to kind of help us be diagnosed sooner, so that we can begin that treatment and stuff like that sooner, to try to increase our survival rate of these different types of cancers. So I do thank you both so much. I appreciate it, and I do thank everybody who tuned in tonight. You all enjoy the rest of your day.
Thank you. You too. Take care, everyone.
Thank you
Bye-bye.
all. Be safe.